Hello, everyone, and welcome to today's webinar, Trauma Verification's April Q&A web conference. For best sound quality, we recommend that you connect to audio by phone. If you're not currently connected by phone, look at the GoToWebinar control panel on the right-hand side of your screen, select audio, and then select phone and dial into the number that appears. And now I'd like to introduce Molly Lozada, Trauma Verification Program Manager. Molly?
Thank you. Thank you, everyone, for joining today's web conference. And Rachel and I will be covering today's session. Just going to go over a few housekeeping policies. Continuing education. To qualify for CE, you must attend at least 15 minutes of educational content. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar ending with instructions on how to claim those. If you have any questions about your CE or during the webinar or any questions about the webinar, please feel free to email us at cotvrc@facs.org. The goal for today's webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient, understand the processes and standards involved in an ACS trauma verification site visit, and how following these will positively impact the quality of care of the injured patients at your facility. So with that, we're going to go ahead and get started. So we've made some changes to our slides, and hopefully it'll be a little easier to follow. Just for those trauma centers or new trauma program managers or medical directors who are not familiar with our process, if you have a copy of the Orange Book, there's a copy available as a download PDF. And again, when using the Orange Book or the Resources Manual, make sure you also use the clarification document and the change log. As many of you know, the change log document is what really notes all the changes in the criteria. Unfortunately, the most recent copy hasn't been uploaded to the website just yet, so anything presented in today's webinar will be done later this week. Just a couple of resources. I put them all on one slide, so if anyone is looking for the recording of the webinars, the stakeholder public comment website, frequently asked questions, tutorials, and participant hub, it's all located here. I do want to point out that we did just post a new tutorial for trauma centers who are preparing for a site visit that is available on the resources website as well. All questions are pulled directly from the questions submitted. There have been no edits made to the contents of those questions. If your question is not answered today, the question may require more information and will receive a response from ACS staff within a week after the webinar. Just a few announcements. Next verification Q&A webinar is scheduled for May 31st, and the deadline to submit questions is May 16th, and we are going to keep the same time. It's 12 to 1 p.m. Central Standard Time. And I'm going to go ahead and transfer this to Rachel for scheduling reminders.
Good afternoon. Site visit applications. The application must be received at least 13 to 14 months in advance of the requested site visit dates and must be before the expiration date. And again, this holds your spot and gives centers plenty of time to complete the PRQ. Also, when you are sending in your site visit application, all Level 1 trauma centers must also complete the Orthopedic Trauma Liaison, the OTL form, with a copy of the OTL's curriculum vitae when submitting a site visit application. And for trauma centers that have surgeons, physicians who trained or are board certified overseas, they're required to apply and be approved by way of the alternate pathway criteria. So just to reiterate, non-boarded surgeons or physicians who trained in the U.S. or Canada are not eligible to go through the alternate pathway. So on the application, just be sure to add the name and specialty on the application. And also, at this time, we are accepting applications for February 2019 and moving forward for the rest of 2019. Okay, providing quality trauma program contact updates. So from the time you send in your application to the time we start scheduling, we know that there could be some staff changes. And you can update these at the Participant Hub Account Center, or you could also notify the VRC office as soon as possible. And we definitely need these updates because when we're sending out confirmation emails and final letters, we definitely want to send to the appropriate people so it doesn't delay anything. And also, if you could, on the applications, if you could just note credentials such as MD, RN, EMT, etc. So pre-review questionnaire online access. So once your application has been received in the VRC office, Anita Johnson will provide you with an email receipt of that confirmation. And in that email receipt, the logins are pretty much right in the middle of the page. You'll be provided your logins there. And then also, the online PRQ can be accessed at the following website, as well as a copy of the PRQ in Word can be downloaded from the following website. We ask that you do not submit payment with the application. You will receive an invoice 60 to 90 days before the site visit, and your center will be billed annually for the Trauma Quality Program fee. Below there's a link there where you could see a fee structure. So scheduling site visits. Visits are being scheduled quarterly, and centers are being asked to provide us with the exact dates you would like to have your visit. So right now I am finishing up a few in the third quarter, and we'll be starting scheduling for the fourth quarter. So if your center is having a visit in the fourth quarter and you have not yet been able to send in exact dates, if you could do so as soon as you can. And ideally, the visit will occur on those dates that you chose. Once the review team has been secured, you will receive a confirmation email which will list your reviewers and their complete contact information. And visits will typically be scheduled within 120 days prior to the visit. Site visit preparation with reviewers. Reviewers will book their own flights through the ACS Travel Department, and they normally do this approximately 20 to 30 days prior to the visit. The center is responsible for arranging and covering hotel accommodations and also the ground transportation for the reviewers. And we ask that you please contact the reviewers directly within 30 days of the site visit. And this is basically to get their flight itinerary or send their hotel confirmation and set up ground transportation. And if by chance it's getting closer to your review date and you have not heard back from the reviewer, which does not happen often, but please let me know if so. So we want to make sure that you're set to have a successful and smooth running visit.
Thank you, Rachel. So we have some criteria updates, and some of you may have heard some rumors about these updates, so hopefully I will clear up all those rumors and any questions you may have about this. And again, if you have any questions following the webinar, please feel free to email us. So one of the things that our chairs wanted us to clarify even further from what is currently on our documentation is regarding universal screening for alcohol use. As you know, we have provided clarification on this, and here's a little bit more. It is acceptable to, it's applicable to eligible patients. So now we've added eligible patients, which is defined as alive and participatory, regardless of activated or non-activated who meet inclusion criteria with a hospital stay of greater than 24 hours who are admitted to the hospital and are entered into the registry. So the latter part did not change. It's the eligible patients. And one thing that's not on here is that this does include orthopedic and neuro patients for trauma. Any patient with an altered mental status and deaths should be excluded from the denominator, as these can't get screened. So again, we just clarified that a little bit further. And now, for the big reveal, and I'm sure everyone's going to be excited about this as we are, continuing medical education. The change is effective immediately. So this is effective with any site visits that occurred on April 15th and after. So if you're preparing for a site visit this coming year, this is now in effect. And I will talk about focus visits if anyone was cited for deficiency, and I'll cover that a little bit in a couple of slides in. So the CME requirement has changed to 36 hours, which is 12 hours annually, from the standard 48 hours, 16 hours annually. So again, we went down to 36 hours. There was no change in the following criteria, just a little bit more explanation. In a level 1 and 2 adult and pediatric trauma centers, trauma surgeons, pediatric surgeons, and the specialty panel members, which is emergency medicine, orthopedic surgery, neurosurgery, and the ICUs, that being med and neuro, participating on the trauma call panel must demonstrate evidence of ongoing trauma-related education. So that's a standard requirement that we currently have now. What has again, this is another change. So in level 1 and 2 trauma centers, the trauma medical director must fulfill the requirement 6-10 by obtaining and demonstrating a minimum of 36 hours of verifiable external trauma-related continuing medical education over a 3-year period, or they can do it over the course of 12 every year. And level 1 and 2 pediatric trauma centers, the pediatric trauma medical director must fulfill the same requirement, of which 9 hours must be pediatric specific. So again, we're clarifying that further. So the following is what has changed now. For the trauma surgeons, pediatric surgeons, and specialty panel members, emergency medicine, neurosurgery, orthopedic surgery, and ICU providers, participating on the trauma call panel, staying current with their board certification meets the CME requirement. And I listed all the CMEs that this impacts, and basically what this means is that your liaisons and your other non-liaisons, as we refer to them, your other trauma panel members are now required to be current, as it's a requirement, being current in their boards, but we're taking that as meeting the CME requirement. With that said, there may be some expected changes to this, and the reason is that the board certification services for emergency medicine, neurosurgery, orthopedic, etc., they're currently changing their board maintenance of certification. So policy. So I know everyone received an email from me about 2 weeks ago that we were going to move towards MOC, maintenance of certification. Well, we learned as soon as I released that the American Board of Surgery changed their policy to continuous certification. So we kind of pulled that back and just went with just that everyone on the trauma panel is current in their board certification. And once that language with all the other boards gets sorted out, or when that change is made with all the other panels or all the boards, then we will come back and let everyone know there's maybe another change. So I just want to make sure that everyone was aware of that. This piece did not change. We just kind of encompassed it in one general statement. The trauma medical director is expected to assess the individual surgeon's adequacy of trauma care knowledge in the ongoing professional practice evaluation, which is the OPPE process, and retains the right to require additional CME or internal education process that stems from the trauma center's performance improvement and patient safety process. For the specialty panel members, such as emergency medicine, neurosurgery, orthopedic surgery, and ICU, the OPP may be done by the specialty liaisons with approval of the TMD. So what this means is that even though we have changed to not requiring CME and just having everyone current in their boards. What this really means is that the trauma medical director and the specialty directors retain the right that if during their OPPE evaluation that one of the providers requires more education, let's just assume for PEDS, that it is within their right to ask them to have additional CME or have an internal education process. And if that's the case, then during the site review process, that is what the reviewers are going to look at. So again, that is a slight change from what is currently in the Orange Book. And of course, there wouldn't be nothing less than having CME clarifications already, because we try to cover everything we can possibly cover in questions, and sometimes we just may miss something. So if I missed anything, again, just email us at the COT VRC inbox, and hopefully we'll address that. So the new change, or the updated change, being current in board certification, does extend to recent grads and board eligible providers, and it also extends to lifetime, which is referred to as grandfathered physician surgeons. So if they're current, well, board eligible is being current in their board, so they're good, and the grandfathered physicians are also good in meeting that requirement. Trauma surgeons and specialty panel members, emergency medicine, neurosurgery, and orthopedic surgery, who have been previously approved by way of the alternate pathway criteria must meet this requirement by obtaining and demonstrating a minimum of 36 hours of verifiable external trauma-related CME over a 3-year period, or by participating in an equivalent number of hours in the trauma center's internal education process, or a combination of both, CME and IEP. So for the alternate pathway members, as you know, they're not boarded here in the United States or in Canada, so by default, they have to meet the CME requirement. The trauma program is expected to have a copy of the provider CME and IEP documentation at the time of the site visit, so no change there. They are still required to meet the CME requirement. I do want to say that the PRQ, because it takes us a little time to update that, we are working on updating the PRQ to reflect the changes that I just presented. So for the time being, if you're working in your PRQ or will be working on your online PRQ, just make sure you select yes to the CME questions. When it comes to the section in the appendices, you can leave the CME column blank. You don't need to enter anything in there. And what is not on here, and I will stress this now, is that when you are entering the board certification dates in the appendices, to please make sure you enter their expiration date and not when they first were boarded. That will make it so much easier for the reviewers to know that they are currently boarded. So just be prepared that if there's if the reviewers have any questions, they may ask you to, for documentation on their boards, but it's, nothing of that changes. We currently ask this information in our PRQ, and the reviewers verify it based on what you provide us. So one of the things I did not put on here is about the focus review. So if any trauma center was cited a CME criteria deficiency, and if that's the only CD that was cited, you can send us a letter, and what we're going to do is we're going to follow up with you. But if you can send us an email through the COTVRC at FACS.org inbox and let us know that you were a trauma center that was cited a deficiency for CME, we will let you know what you need to do to resolve or address that deficiency. Primarily, if it's just the one deficiency that you were cited or the trauma center was cited, then you can send us a letter stating that you confirm or you have verified that all your providers are currently board certified, and we'll accept that as a resolution. So, but if it's one CME and two others deficiencies that are not related, then you certainly can do that. Submit the documentation at the time that it's due or during the on-site visit. So again, if you have any questions, if you're a trauma center that is pending a focus review, just drop us an email and we'll go ahead and address that. So we're going to go ahead and move on to general questions. TPM reporting structure, is it acceptable for the trauma program manager and program staff to report up through nursing and TMD to the CMO? So we've had this question come up quite often, well, in probably a few other webinars, but we've had it come through the office many times. And what I'll say is, while we don't have this written anywhere in the Orange Book or in the clarification document or change log, the expectation, and there is a requirement for this, is that the trauma program manager reporting structure will vary based on institution. As we know, the reporting structure must allow the trauma medical director and the trauma program manager to work side by side to lead the trauma program. So that means that they have to work side by side. So having the trauma program manager report to, say, nursing or to a different department may not be the ideal method or the ideal way to have this work. So I know we're currently in the revision process, and we are going to speak to that structure process when the time comes. What is the expectation for the surgeon admitting 90% of trauma admits? Is this activations only? Does orthopedics count? So I took this this question to mean that if there's expectation of an expected number of patients admitted to a specific surgeon or to a service based on activations, and the answer is no. The ACS does not have a surgeon-physician admitting threshold. The only threshold we hold a surgeon to is the response for the highest level of activation, which is 80%. Could you give examples of acceptable competencies for FAST exams and the PI process for FAST exams? So again, this is not a requirement. I know it's come up before in a couple of webinars, and I do want to stress that FAST is not a requirement. We do have 2 questions in the PRQ that asks about the FAST exam, who provides the FAST exam, and how do you QI or PI those exams. Those are really the 2 questions that are in the PRQ. So I guess for PI process, there could be regular meetings, should be conducted to review FAST exams. I know I have on here by the ED emergency director, but really it can be, it can be any provider in the ED area that can lead that. And ideally, you want to review any significant issues associated with the use of ultrasound in trauma patients, and that should be presented to either the emergency medicine quality improvement, QI meeting, or an equivalent meeting that discusses those kinds of issues. And if there's issues with that, then they can just move up through the peer review. Site reviewers would look through the case reviews for cases that had FAST exams and whether any issues were presented and if there were any PI notes on that discussion. So really the reviewers are going to look through the case reviews and see if there were any issues with that and if the hospital identified it and what they did to resolve it. How often is the PRQ itself reviewed? May I suggest that when questions in the PRQ change in any form, posting to the webinar would be helpful. I agree. This is a great idea, and I will take that into action. I think we're going to I think we definitely will add a segment to our presentation, our webinar presentation, to classify updates to the PRQ, and I just suggested update PRQ questions, and I can cover that starting next month. If there were changes, I will definitely present those, and if there were no changes, then I definitely will speak to that as well. So currently there were no updates, but as I mentioned in the CME change criteria, we will have some coming up soon. In reference to answering the PRQ, how is social worker defined? Is the question related to DC, which I'm assuming is discharge, planning, referral to services? So social worker is defined as a credential provider. That's how it's in the book. We don't state that it has to be someone that has their master's or a physician per se, but we're stating that it has to be a credentialed provider who is capable to perform evaluations and counseling. The credentialing criteria, whether that be training, education, or any additional credentialing criteria the trauma center imposes, will be determined by that institution. So that will vary by institution. With regard to PRQ for pelvic ring, acetabular with neurological deficits, we have stated this in previous webinars that that question below, as you see here, see how many of these patients have neurological deficits. That question is not applicable to this question, so you can disregard or skip question 18C. So this person who asked this question, we're not looking for any additional data for the neurological deficit, so you can just leave that blank. Related PTS screening for trauma patients, what info would surveyors want to see? Again, this is not a standard. I believe that it's coming up more and more frequently now, but it is not a standard. I don't know if this will become a standard in the new edition of the resources manual, but for the time being, what reviewers will be looking for is whether or not the trauma center provides screening for trauma patients who pose PTSD, and if so, what are the guidelines? What do you do for those trauma patients that do have PTSD? So again, what the reviewers are they may ask the question, and if they do ask the question, they may want to see what your protocols are for PTSD screening. And if you have them, that's great. If you don't have them, just be honest with the reviewers that you don't have that. And if you do, again, just, show them your guidelines on evaluating, treating, and managing those patients with PTSD. If the trauma program is experiencing some personnel changes, such as the TMD or trauma program manager, would you recommend postponing a survey, and how long? So I answered this a couple of different ways, but I probably have even a couple of different other ways to answer this, but I think this is probably the easiest way to look at this. It depends. If the center is currently verified, is one, and second, the type of personnel changes that may impact the visit. So, for example, I'm taking the example they provided me here, which is the trauma program manager and the trauma medical director. So if the center is currently verified and say the trauma medical director or the trauma program manager leave unexpectedly, the easiest thing to do is to appoint another person in one of those roles. So it could be another trauma surgeon that's been serving on your trauma panel, or if you have someone that may fill in the role for the trauma program manager in the interim, I would certainly do that. What ends up happening is, even if they're new to the role, everything gets prorated. The most important thing is that the trauma medical director, if you're appointing a surgeon, that they're current boarded, and the trauma program manager, that they're able to provide or answer questions that may come up during the review process. I think that may be the challenging piece of it, if you have someone new to those roles, that they may not be able to speak to cases that went through the PIPS process. And I think if you possibly have someone that's been there during that process, if there's something, if they've been to the PIPS review process or been through it, then it would make it a little easier. But I think that would probably be the most challenging aspect of it. In addition, if the visit is postponed, again, speaking for a verified trauma center, if the visit is postponed, then that may impact your verification status, which then may impact your state designation process. So you want to definitely look at, if you are thinking of postponing this for a verified trauma center, look and see how this may impact your designation process. If the center is not currently verified and the TPM or TMD leave unexpectedly, then you do have the option of, again, substituting someone in that role or in that position and moving forward with it, because, again, we're asking that they be currently board certified. They don't have to do, if they do peer review, that's great, then that gets prorated. Two, you can postpone the visit until you have someone secured in that role. And depending on how long it takes the trauma center to secure someone in that role, it's really up to the trauma center. The other thing you want to factor into is that if you do postpone that visit, let's say you have a visit scheduled already, say for June, and you postpone that visit, Rachel's probably not going to be able to get you in for another year unless there's a vacancy somewhere along the way. But ideally, it's probably going to be another year before she can reschedule that visit. So just things to consider when you're thinking of postponing a visit. And again, Rachel can speak to this and I can speak to this, so you can definitely send us an email if you have any questions. This is my first verification. What should I expect as injury prevention? What will the surveyors be looking for? Again, if you're new to this process, there's a couple of tutorials that you can look at. There's the first steps, and then there's the site visit steps that I have covered now. In respect to the injury prevention, the reviewers will review how the trauma center is helping the community and kind of helping them with, like, for example, possibly going out to venues or to schools or partnering with another hospital and providing education to, like, senior citizens or even kids in high schools on, preventing falls and risk factors and alcohol abuse and things like that. That's what the reviewers are going to look at. They're going to look and see what the trauma center has done in the community. And again, you can partner up with another hospital, another agency like the police or the fire department, things like that. So there's various things to do about that. To clarify, we can submit exact request dates for a verification visit rather than a range of dates. Rachel covered this earlier on, and that is correct. She will schedule your visit based on the 2 dates that you provide on the application. And if you got in super early and were unaware of this, that's okay. She can definitely take that into consideration if your visit's currently pending review in the 4th quarter. So go ahead and reach out to her when you get a chance on the COTVRC box. One of the things I want to stress is that we do make an effort to avoid scheduling visits during holidays and during conferences. So we try not to schedule around East, West Clinical Congress, Pediatric Trauma Society, STN, etc. So we try to work around that just to give everyone an opportunity to work with their schedule. But if you have a 2-date range or 2 days in mind, go ahead and provide that to Rachel. You may want to also provide her additional dates just in case it's a little challenging to get reviewers. Please clarify the status of a trauma center when they have a site visit that results in a 1-year focus review. Are they considered a verified trauma center during that year prior to the date of the focus review? Yes. So for any trauma center that received a 1-year verification, they are verified, no different than someone who had a full 3-year verification. This information is not released to the public, so if you have received a 1-year verification, you are technically verified through the expiration date or through the resolution process. So that 1-year period that you're verified, that is what we consider the focus period. So it's one and the same. And the resolution process is it's what we call, like, for example, if you're waiting for your report, you had a focus visit and you're waiting for your report, we technically still consider you verified. And if you're a trauma center that needs to submit documentation to us, again, until you receive a final letter from me or Megan, then you are verified until said date or said letter. So again, 1-year focus or 1-year verification is you're still a verified trauma center. We're going to go ahead and move on to CD-related questions. For surgeons responsible to the highest level of activation are patients who arrive via private auto in the measure, meaning are they part of the 80% threshold that we ask for? And the answer is yes. If the highest level of activation was triggered upon assessment of the patient, so if the patient came in via private auto and the patient was assessed and determined to meet your highest level of activation and the activation was triggered at that point in time, then you will factor that into your 80% response time. Does the trauma surgeon have to be contacted on level 2 activation before the patient is transferred, or can the ERP manage it? This will depend on your level 2 activation criteria and protocols. If the protocol calls for the emergency room physician to transfer without consent or with consent of the trauma surgeon, it should be documented in the EMR and reviewed through the PIPS process. So if it's a trauma patient that needs to be transported, again, we don't want to delay care. We don't want to delay transporting that patient. So if a conversation is had via phone with the trauma surgeon, you want to make sure you're documenting that information. Or if the trauma surgeon is expected to arrive, you want to document that as well. As an adult level 2 trauma center treating and admitting some minor pediatric cases, what are the credentialing, education, or other requirements for the trauma surgeons or APP providers? For the non-pediatric trained providers at this adult trauma center or advanced practice providers managing pediatric patients, the credentialing process may consist of, and this is not exclusive, of having PALS, certification, annual pediatric trauma continuing medical education, or pediatric-specific content covered in the internal education process. Again, this is not an exclusive list. This is just some suggestions of what that pediatric credentialing may consist of. For the APPs, and this is no change to this, if they are part of the trauma activation team, they provide evaluation and assessment to the trauma patient, they are required to be current in ATLS. What level of involvement should the trauma medical director have in the trauma certification of medical practitioners in the ED, neuro, or ortho? The trauma medical director must have the authority to provide input in the credentialing of providers who will be involved in the care of trauma patients. That is a requirement. It's in the Orange Book under CD 511. So they should definitely have some authority and some input in providers for ED, neuro, and ortho. Should the profession evaluation, which I'm assuming is OPPE, of trauma surgeons performed by the trauma medical director be shared with the individual practitioners? Absolutely. Again, if the question is, should the trauma medical director share the OPPE evaluation with the individual practitioner that he or she is doing an OPP on? Absolutely, they should share that information to address any performance or patient care issues. If they don't share that, they're not going to know that they're doing something incorrect or there was an issue with their care or their performance. So you definitely want to have that shared with the practitioners. Does the trauma surgeon need to see all mid-level activations, or can the trauma service advanced practice provider see the patient in place of the attending trauma surgeon? So yes, the short answer is yes, they can. For the limited tier, which is a second tier activation or mid-level activation, the APP may be the primary responder as long as the hospital has credentialed them to do so, and they must be current in ATLS. So again, if they're part of, they're seeing the trauma patient, they're evaluating the trauma patient, and they're assessing the trauma patient, they are required to be current in ATLS. With this said, the limited tier criteria protocols must clearly speak to this, meaning the APP responding or resident or whomever, or the PA, and in addition have language for the type of injuries and time expectation for when the trauma surgeon is expected to respond to those mid-level activations. All must be monitored through the PIPS process to ensure there are no delays. Can a trauma patient with injuries noted for multiple rib fractures and scalp laceration be seen in consultation by any surgeon, or does it have to be a trauma surgeon? The question was a little confusing to me, so hopefully I answered this appropriately, and if not, please reach out to me. For the consultation tier, which is, I'm assuming that's what this is, the primary responder may be a credentialed provider. Again, it could be the APP or the general surgeon, emergency physician, or an advanced practice provider, as long as the hospital has credentialed them to do so and they have either taken ATLS once and for the APP current in ATLS. Again, that's what we're asking for in the consult level. Board certification. If an ER provider is board certified in family medicine before 2016, is he eligible to take trauma call? Yes. The emergency physician or the emergency medicine physician boarded in family medicine is eligible to care for trauma patients. The change that this person is referring to is in the clarification document, and it speaks to those physicians who completed primary training in 2016 and after. Is it acceptable for a credentialed trauma surgeon to manage a neurotrauma patient until the neurosurgeon arrives as part of the routine neurosurgery response, not a contingency plan? So the answer is yes, and again, I'm taking this to mean that this is not part of the contingency plan, but part of the consult level or part of the trauma activation. The trauma surgeon may be credentialed to provide the neurotrauma patient, manage the neurotrauma patient while awaiting for the neurosurgeon to respond. However, the trauma surgeon cannot account for the 30-minute specialty response. So it's a little different. And again, if this person is on the webinar and I did not clearly answer that, please reach out to me. But the trauma surgeon may be credentialed to manage the neurotrauma patient while waiting for the neurosurgeon to respond. Can the surgical critical care intensivist fulfill the 30-minute neurosurgical response if they are in contact with the neurosurgeon? Again, I'm taking this to be the neurosurgical intensivist. If that is correct, yes, they may respond when consulted for neurosurgical care. If that is the case, there must be guidelines for the types of injuries they are approved to respond to, and there must be clear documentation of the discussion with the surgeon specialist on the plan of care, that being the neurosurgeon. If a neurosurgeon is on call for both trauma and the stroke center at the same facility, is a backup neurosurgery call schedule required? Yes. Trauma and stroke are separate programs, so there must be either a backup call schedule or a contingency plan in case the neurosurgeon becomes encumbered with a stroke patient. So that could be another, again, a backup call schedule or part of the contingency plan, but you definitely need one or the other if the neurosurgeon is covering multiple call schedules. In an adult center, should we review only pediatric admissions to the hospital or all PD trauma patients who come to ED and transfer? The center must review both. So it covers CD 4-3 and 10-6. The pediatric admissions and those pediatric patients that were transferred. So you want to review all your transfer outs. It's one of their requirements. When does the clock stop for IR, radiologist at bedside or getting the patient to the table? Does the radiology attending need to be the one to respond, or is evaluation by resident appropriate? The clock starts when the call is made requesting the service, and it ends at bedside. The radiologist resident may provide the evaluation as long as the hospital has credentialed them to do so. Can the medical director of the SICU be a pulmonologist? Can a pulmonologist supervise PGY4 or greater surg reds from home? No. The surgical ICU director at a level 1 trauma center must be a surgeon who is currently board certified in surgical critical care. The PGY4 and greater residents must be under the supervision of the trauma service, so it cannot be a pulmonologist. Does the designated ICU liaison to the trauma service need to be an ICU intensivist? It does not. The ICU liaison is typically an ICU director who is board certified general surgeon. Since this is a level 2 trauma center, the co-director could be an ICU intensivist, but the other director, or I should say the director, needs to be a board certified general surgeon. What policies, if any, exist for credentialing of advanced practitioner staff? I've stated this several times that the credentialing process for APPs will differ by trauma centers. There's currently one criteria that we have that we hold the trauma center to, and that is that during the that the APPs who are participating on the trauma team during activation will provide evaluation and resuscitation efforts to the trauma patient must be current in ATLS. Some credentialing examples, again, this is not limited, could be based on maybe requiring ATLS or PELS, requiring them to have external, internal CME, trauma-related CME, or documentation of performance as measured by the PIPS process. It could be a combination of any of those. So again, it's not limited to those, but those are just some examples. Is it a requirement for CRNAs to take ACLS one time or ongoing? There are no requirements for CRNAs to take ACLS. Please clear up some confusion on the exact terminology for PIPS process and reviewing deaths, mortality with opportunity for improvement and or mortality without opportunity for improvement and or unanticipated with opportunity for improvement or other terminology. I think there's been some confusion on this, and this has not changed. This is still the same. It's not in the Orange Book. It is in the clarification document and also in the change log, and it remains the same. It's mortality with opportunity for improvement, mortality without opportunity for improvement, and unanticipated mortality with opportunity for improvement. Now, I do know there are some centers that they can't use these terminologies, and that's based on their state laws or bylaws, and that's okay. What you want to do is somehow during a site visit be able to pull these categories out for the reviewer. So you can certainly have some unique identifiers within your own program to identify what those deaths are for these specific categories and present that at the time of the site visit. Death reviews, people who are terminally weaned and expire when they are reviewed at M&M, would this be an anticipated mortality because we know when we pull support they will not survive, or do we look at it with would they have survived the injuries if family had decided not to pull support and see it as an anticipated? So, you know, you can look at this in either way. I think what's important here, you want to look at this case and ask questions such as, you know, would the patient have survived the injuries if the family had not decided to withdraw support? And if that's the case, how long would that patient have survived? So again, it can be reviewed in either way, but I think you definitely want to ask the question, would the patient survive the injuries had they not withdrawn support, and maybe classify that as unanticipated. Again, that's just one way to look at it. It's not a for sure way to look at it, but you definitely can look at it that way. Do hospice discharge cases without issues need to be presented at PIPS meeting, or is it okay to peer review outside of the meeting? Again, I'm assuming D/C is discharged. Just as with any other discharge trauma case, the care will be reviewed by the trauma medical director and trauma program manager. If there were any issues found, then it can definitely be reviewed at peer review or outside of peer review if that's the case. What is meant by continuous rotation in trauma surgery for senior residents? PGY4-5, is this 24/7? Does a level 2 trauma center have to have residents, and specifically PGY4 or 5? So level 2 trauma centers are not required to have residents. Some do, some don't, but it's not a requirement. This is for level 1 trauma centers. The continuous rotation is not about having a resident on every day or every month, but more about having the resident education experience with a full curriculum and a dedicated teaching staff for a period of time over the course of the year. What is not acceptable is having a resident residents who are on the service as an elective, and this is something that our chairs strongly believe. So it's not about having someone on the service 24/7, but more of having a resident be on the service for educational experience, and that have a full curriculum, and along with a staff that's dedicated to teaching. Alcohol screening. Does screening for drugs and alcohol on trauma patients require documented lab levels, or will a screening interview suffice? Screening for drugs and alcohol does not require lab levels. If that is a policy within the hospital, that's certainly acceptable. A screening tool or metric will suffice, and there's a couple of examples on our resources webpage. We do stress the importance that if you are using a screening tool, that is documented and tracked. This is one of the areas where we do see trauma centers being cited a deficiency for not having this information documented in the patient's chart. What is the minimum age requirement for alcohol experts? This is for level 2, and the minimum age for screening and intervention will be defined by the trauma center. So ACS will not limit that minimum age, and we will let the trauma center define that age requirement. And that concludes today's webinar. I would like to thank everyone for participating, and thank you.
And thank you to Trauma Verification staff, and thank you for everyone for attending today's webinar, Trauma Verification's April Q&A web conference. If you have any other questions, please contact cotvrc@fax.org. And on behalf of Trauma Verification and our presenters, thank you for joining us today, and have a great rest of your day.